Thank you for inviting me, fantastic. I'm going to try and separate myself from the lectern if that's possible, because I've been told it's really important that you can see my knees. Helps communication. I'm not wearing shorts though, unfortunately. Thank you Robin and James for your talk. Then we're talking about what you can learn about obesity research using big data from a transport perspective. And we're going to try and stick to some of those 5 commandments in my talk. I'm going to talk about what we can learn about obesity research using big data from an epidemiology perspective. And I know that some of you will kind of come from that background. I'm not trying to teach grades to suck eggs, nor am I trying to say that this is the right perspective. I'm hoping there's lessons I can learn from your perspectives as well when it's your turn to stand up in front of everyone. Let's see. Brilliant. So, how am I talking? I'm going to give a few examples of big data research, how to use big data in a way that's relevant to obesity research, just to kick off with, and identify some of the problems that I see with research using big data. And I'm sure you'll be able to identify with some of those, and Robin and James have touched upon some already. I'm going to talk about some of the methods that we use in epidemiology to deal with some of these problems. I'm just going to kind of talk about them in fairly broad terms, and end with some kind of tips for how we interpret data. And I think there's some overlap there again with those 5 commandments that we've seen already. But the first thing I'm going to want to start with is paying homage to that 4th commandment, which was giving a definition of what I mean by big data. So this is where I'm coming from. You might well have a different definition. I know that Claire Griffiths has gone around some of us asking us for our own definitions. And I am going to slightly make it contrived. I've gone for 3 V's in my definition, which I've sort of stolen from the NIHR. So my definition, this is where I'm coming from, is that big data's got something to do with large volumes of data, so it's big in as much as there's lots of it. But it might also be big in terms of, let's see if there's a laser. It is fantastic. In terms of the velocity that comes at you. So you might have kind of real-time monitoring. We're familiar with kind of all these wonderful things that people use in sort of diabetes research to sort of like monitor people's glucose level in real time. So it might be that there's just lots of data that's coming at you really fast. Or potentially, and this is a very more vague term, it comes at you in a variety of different formats and complex data structures. So it may be to do with, you've got different places that these things are coming from, how you combine them, the sort of like the structures that the data form, that mess, that network that it looks like when it hits your inbox. So that's where I'm coming from with my kind of fairly broad definition of big data. I think it's quite similar to the one that James and Robin were using. So, examples of big data that, as I see, that's relevant to obesity research. Administrative data is one that people might use a lot. So here's some this is census data, isn't it? There's lots of that, lots of census data. Everyone has to do that. So you might have 70 million pieces of census information. Potentially it could be death certificates. So here's an example of a death certificate. You can't control the kind of information really that's recorded in the census on a death certificate. It is what it is. You're sort of stuck with the information that's out there. You can't make that any better than it is, and that can lead to some issues at times. GP health records, another source of big data, and combining these can be a challenge. And maybe cancer registry data. It's all administrative data. You can't change what's recorded there. You can't improve the quality of it. PES data, hospital episode statistics. These are all kind of sort of big data. We've got lots of information on lots of people, or certainly on lots of people, and we can use it in research into obesity. So that's administrative data, and connected to that is consumer data. So CGRC in Leeds has lots of consumer data, but again, it's not something necessarily that we can control what's being recorded. We're just trying to take advantage of it for our research into obesity. So here's an itemised till receipt. It may be that you've got information on a very detailed level of what people have consumed as consumers or purchased, or possibly loyalty cards. Other loyalty cards are available. But maybe you have a loyalty card information, which, again, you can't necessarily control what information is being collected by the supermarkets or the companies which run these loyalty cards. But there's a lot of data that's out there that maybe we could harness. Another area of a kind of different type of data is the spatial data. This is big in as much as there's obviously lots of different types of areas in different regions around the country. But it's also a bit complicated because you've got that data at different levels. So it's not just big in terms of the amount of information, but it's big in terms of you've got information at different levels. You've got it in a variety of different formats. Robin and James talked about how they've tried working with the different output areas. That was too small, that was too big, how we combine them up together. And that can lead to challenges for us. Other kind of spatial data, I'm glad I included this transport data now. It's my non-interactive map. And these are just checkpoints of traffic going into Leeds city centre. There aren't many checkpoints, but they're recording every single car movement in and out of Leeds in a 24/7 period. So that's a lot of data. It's not big in terms of lots of checkpoints, but it's big in terms of it's coming at you at high velocity, sometimes literally. Yeah, thank you for that. I'm still a scientist. So, real-time monitoring is another area of big data which is relevant to obesity research. This is time series, but one that we're more familiar with in Leeds, I think, is this idea of having real-time monitoring of glucose concentrations for an individual person. Just a little implant up beneath the skin, kind of Wi-Fi to your mobile phone, upload at regular intervals. You've got a huge amount of information, minute by minute, on an individual person. You might only have this on 20 people, but it's still big data in the sense that we've got a massive amount of information and that we can harness. And what I'm hoping to sort of lead up to is how the different kind of areas of different examples of big data we can maybe learn from where there's overlap with other things that we want to do. Genetic epidemiology is an area where we've been dealing with big data for a while now. So here's a genome-wide association sort of scan. I can't remember what it's about, something to do with diabetes. And you've got information on maybe 100,000 SNPs or something like that. And potentially some of those are correlated with each other if they're inherited together. So it gets complicated. But it's also big. You might have it on lots of people. You might only have it on a few people. But it's big data because you've got 100,000 pieces of information on everyone. You can maybe sort of target one particular chromosome, one particular position on a chromosome. This to do with glucose. And you can see there's something interesting going on. Something interesting going on here. Position 52. So I think we can learn from genetic epidemiology as well. Anyone here into molecular biochemistry? Protein folding? This is big data. Maybe we're not in this network. But proteins are very complicated, lots of data, possibly kind of real-time information about 3D sort of modelling. Is there anything we can learn from these guys? And I also think that people involved in cluster randomised controlled trials, that's big data in the sense that you've got complex data structures and you have some of the same kind of problems in as much as if you were to kind of randomly allocate a patient attending a GP to a particular intervention, well maybe they talk to their friend. So that leads to contamination. So you can't randomise individuals, you have to randomise people in clusters. And as soon as you do that, then the people within each cluster are more similar to each other than to people in other clusters. And so you end up with these kind of correlated data structures as well as hierarchical data structures. So that's a bit more complicated, and can we learn from things which people do in that setting? I should also add in weather forecasts. That's real-time data. I was looking at Robin's code, thinking, what have I done with coding like that? And I'm thinking, oh, I've got a weather station. But that's big data, because you're getting every minute what the weather is in your garden. And it also affects cycling, I imagine, so maybe you can link that in. I'll send you the link to my weather station website. So these are just examples of big data, and I think the idea is that, you know, some of us will be involved in some areas and not others, but there are some problems that we have in common in our research, and we can hopefully learn lessons from each other. And I'm going to just talk about things from an epidemiology perspective. So, some of the problems for some of these examples, like the administrative data, the consumer data, is inability to influence our choice of measure. Sometimes we're just stuck with collecting information that we have. We can't make it any better than it is. And that can be a problem, in as much as we can't improve the quality of the measure that we have. I think one of Robin's kind of 10 commandments was, thou shalt not do big data until you've done small data. One of the things that we can learn from the small data is actually that the quality of our outcome measures and the quality of our exposure measures is really important. If they're poor quality measures, then no amount of data is going to make up for poor quality data. It's also quite tricky sometimes if you've got big data to try and find appropriate controls. I should have asked Claire if I could use an example for some work that she's been working on. In Leeds, we have, I'm going to do it anyway. In Leeds, we have an intervention called Let's Get Active, where everyone in Leeds is invited to use the council leisure facilities kind of at off-peak time, but for free. This is fantastic. You know, you can take your kids swimming for free on a Sunday afternoon. And I once asked sort of someone at a conference, what would you do with all this kind of rich data? And everyone fills in a questionnaire, and they have, it's like a loyalty card in many ways. And everyone knows exactly when you've used all the leisure facilities throughout the entire year, who's used them, what they're like, and everything like that. It's an amazing rich source of data. How could we improve upon it? We could get information about people who haven't used the leisure facilities, some controls. So we've got an amazing rich source there, but actually, finding a group to compare it with, you can need in order to be able to draw strong inferences. So that's something which can be a potential problem with big data. You might have big data beautiful on one group, but not on the comparison group, which we need. A huge problem with big data is sometimes it's not complete, it's incomplete data. You may have kind of questionnaire responses from lots of people, but maybe they've left bits out. Maybe certain hospitals haven't returned their cancer registrations or their hospital episode statistics, or certain groups of the population don't get included in it. In epidemiology, people will often use multiple imputations trying to find out what would happen if we had the complete data. It's kind of like a guesstimate, if you like, of what we would have got if we had the complete data. But there are methods related to that issue, and I think potentially with administrative data, with consumer data, when your website goes down, you're having incomplete data. Another problem in common with lots of these things, particularly with the spatial epidemiology, the cluster randomised trials, the transport stuff, we often have hierarchical data structures where we have things on a higher level and then individuals in that level, and then maybe time points. We have information on people. And the trouble is then you have kind of correlation within these groups that makes it look like people are more similar than they actually are. And so you get wrong standard errors, confidence intervals, your p-values are wrong. So the statistical methods that you use have to kind of try and catch up with that. So the hierarchical data structures can lead to kind of correlation between the observations that you've collected, and that can be a problem with big data. You might, especially if you don't actually notice that you've got these kind of correlated data structures. But if you've collected lots of information on lots of people, then those variables can be correlated as well. So social class, education, there's some overlap in the information that they contain. Genetic epidemiology, various sort of genes are inherited, or loci are inherited at the same time as others, so you don't know which one is actually the cause. Big thing with big data is, well, everything's statistically significant. Your p-values will be amazing, but it might not actually be important. So if you have 100,000 people, and 500,000 people, or 1 million people, or you look for some kind of link between exposure and obesity outcomes, it will be statistically significant. I don't want to guarantee it, but it might not be clinically important. So there's a distinction to be made there. Likewise, if you're testing any of your modelling assumptions, you're bound to find that it's not quite perfectly normally distributed. If you use some Shapiro-Wilks test to test whether it's normally distributed, it will say it's not. If P is less than 0.000001. But that's just because with big data, you've got a lot of evidence. But what really matters is it an invalid model? And it won't be invalid at all, it'll be fine. So sometimes we mustn't get hung up on our sort of p-values, ever in epidemiology, but particularly with big data, I think. So everything's significant, you're going to get significant p-values anyway. But even worse, with big data, there's so many comparisons that we can make. You can chop up your data into various subgroups, but you've still got a large amount of information in each subgroup. So it's easy to do it without sort of losing kind of too much power. But then there's so many different ways you can chop up. So every time you make a comparison, you're getting a p-value, and you're accepting a 5% chance that you're going to come up with something which isn't right. It's just a false positive. We know that. But do we know the average number of p-values which are quoted in, say, the BMJ? Anyone have a guess? How many p-values in the BMJ article on average?
One.
Just one article. Yeah.
How many p-values?
Yeah. How many p-values?
7.
20.
20.
Thank you. And each one, you're accepting a 1 in 20 chance. There's a false positive. And that's the BMJ. Now think about maybe a lesser journal. Think about how many p-values you quote in your own. I guess that's okay, but when people just jump on that one answer and think that's exciting, that's when you get the problem. So multiple comparisons can be an issue, and there are methods that people apply to try and deal with that. Usually they mean that nothing's significant, and it serves us right for having done the multiple comparisons in the first place. But I think we can learn from examples like in genetic epidemiology. They've got maybe 100,000 SNPs that they look at, and they have methods for trying which are different from we would use in other areas of research, which can deal with that kind of level of information. So that's quite relevant to big data. Maybe a supermarket might have 50,000 items on sale, and you're trying to see which one's associated with being obese. Well, that's a bit like a genome-wide association scan, as much as the number of items, and of course they're correlated. People who have sort of cornflakes are also more likely to have crunchy nut cornflakes. Thank you. So there could be kind of things which are more similar to each other. So there's that correlation as well. And finally, of course, this is probably what you're all familiar with, is data management issues. Just a huge amount of data. Robin was talking about that. How do you link these things together? How do you do it in a way that doesn't identify individuals? And of course the data security issues as well. So, a lot of these problems are kind of common across a whole range of different sources of big data. I don't pretend that I have kind of the answer to all of those. I kind of share a bit of experience briefly. But I guess the idea is that in a network like this, we can share our own lessons and experiences and learn from others who have done things in different situations. So I'll kind of end with, it's not quite 5 commandments, but it's a little bit like that. You might see if there's some things in common. I guess one of my main points is that we want to focus not on the quantity of the data, but on the quality of the data as well. It's very easy to get excited by the size of the data. I think one of your commandments was don't lose sight of the actual research question just because you've got big data. So focus on the quality as well. One of the sort of like the sayings which I have heard a number of times amongst statisticians is, I'd rather be roughly right than precisely wrong. And the problem with big data is it's very easy to be precise. But unless it's really good quality data, you'll be precisely wrong. So you need to also remember the quality of the data source that you've got a lot of. And sometimes you're better off being roughly right with small data than being precisely wrong with big data. So just remember that when we get excited with the size of our data and our complexity of our data and the complexity of our analysis and everything, not to lose sight of it's the quality that matters, and that's just a basic sort of thing that we learn in epidemiology, but it's so easy to forget, I think, when we just have big data sets. So to help us do that, let's focus on the clinical importance, not the statistical significance, because everything's going to be significant anyway, but does it actually matter? Does it matter what's the size of the effect? And we need to focus our research questions. It's so easy when we've got a huge amount of data to be quite vague and to look at a number of different things. But if we focus our research questions, then I think that helps our study design. It's a good idea anyway to prioritise our research questions. And this way I think we can also avoid problems of multiple comparisons. If we have our priority questions or our hypothesis confirming, and then anything else can be generating new ideas and secondary questions. But, and here's my slightly provocative litmus test for this, is if it's a secondary question, if it's hypothesis generating, that's not a publication. I think it's something we should take forward to the next data set. So, to avoid these multiple comparisons and subgroup analyses, plan things in advance, and then people can't accuse you of cheating and data dredging our large data sources. But moreover, just because we have a large data set doesn't mean that we don't have to try and replicate our results elsewhere. Particularly if we've had problems with multiple comparisons, if we have issues with kind of like loads of different research questions. Particularly if we have issues with data quality as well, actually, because we want to make sure that it's not a problem with data quality. Now we said, don't do big data and small data first. Well, I'm also arguing to do small data alongside the big data to try and either augment the results, give a bit more detail to it, check that the big data results aren't going too far askew. Because these will have different issues. Yes, they're small, that's a problem with small data, but it might be high quality data. So I'd recommend that we use the small data as well. And possibly, dare I say it as a statistician, possibly even use qualitative research methods as well to try and give some kind of colour to the numbers and flesh out what's there. So these are my kind of points. I'll just conclude by saying to networks like this, we can share lessons that we've learned from our own backgrounds, and hopefully we've got enough people here covering enough disciplines that we can do that. Thank you.
Yeah, thank you very much. We can take 1 or 2 questions while I make the transition here with the presentation. Any questions for Darren? Yes, in front.
When you
problems with big data. One of the things you mentioned was hierarchical data structures, making it look like people are more similar than they are. Could you just explain that bit? I slightly missed what you meant.
Okay, so the question's about hierarchical data structures and people within each cluster being more similar to each other than they are in a different cluster. So if you're thinking about patients within a GP, those patients will have the same GP, they'll be in the same environment, the same area, and so there'll be things that they have in common which makes them more similar to each other. You know, not least the fact that they've got the same GP who might apply the intervention in the same way. They would have more things in common than they have with someone in a different cluster who goes to a different GP. So you can measure how similar they are. They might only be really, really subtly similar, but you can assess and measure that, and so you can take that into account when estimating your standard errors and your confidence intervals and your p-values. I can give you some references later.
One more question,
Well,
Janet.
okay, sorry, I can ask you any time, but I mean, you talked about big data. Thank you, Darren. Very nice talk. But you also mentioned small data, and I wondered if you could define small data.
Yeah.
Well, it's
So
just that
in terms of the 3 V's, it's maybe not quite so varied, maybe not quite such velocity, but maybe not quite such volume.
Because, you know, like people like me who've worked within epidemiology, what I thought is big data sets actually might actually be big data, or is it small data? I don't know.
What I mean is, and you might disagree with this one, but measuring diet, food frequency questionnaire, it's easy to do it on a really large cohort, but we know that there are some weaknesses with food frequency questionnaires as well as strengths. And being able to enhance that by having data from a food diary, where you've actually weighed it, or possibly a detailed 24-hour recall, maybe an online one.
Yeah, maybe, yes, good
would be
idea.
really useful to calibrate that. And actually, you know, you can show, as you know, that you're sometimes better off with quality data on a really small number than weaker information on a large number. And sometimes you're actually better off with small numbers.